Good morning and good evening, and welcome to our UNU-INWEH Science Talk. I'm your host, Mir Motin. I am hosting it on behalf of our regular host, Miriam Exden, who is now on travel. Our today's speaker is Professor Susan Elliott, uh, who is working with us, an Adjunct Professor, Environment and Health. She is an health geographer with primary area of research focuses on relationship between environment and health, broadly defined. She has an active research career with 200 plus publications related to global environment and public health with an emphasis on war, gender, aging, violence, vulnerable population. She has also supervised 50 plus graduate students and postdoctoral fellow to completion. Besides UNU-INWEH, she has undertaken a range of administrative roles, including Director of the Institute of Environment and Health, Dean of Social Science, McMaster University, and Dean of Health Science, University of Waterloo. She is the founder and co-editor-in-chief of Wellbeing, Space and Society, as well as the editor-in-chief of Social Science and Medicine. She has a commitment to impactful research in the area of global health, and her research is characterized by strong science policy vision. In 2024, her contributions were recognized through her induction into the African Academy of Sciences. The, the today's talk will be how of the Water-Health Nexus, empowering women to tackle plumbing poverty. The talk will be recorded and it will be uploaded to our UNU-INWEH YouTube channel. With further delay, I am welcoming Professor Susan Elliott to start her talk. Thank you everyone for your joining.
Thank you. Thank you so much, Mir. And thanks everyone for joining wherever in the world you are. I want to talk a little bit today about the how of the Water Health Nexus. And this is, sorry, trying to advance my slide. What I want to talk about is that it's important not just what we do, but how we do it. So I want to talk about the importance of relationship. I want to talk about the importance of the principles, which you'll see in a minute. I want to talk about the importance of humility as one of those principles and how this makes us better scientists. And I want to start and end with a story. So I want to start with a story which is...
Can you share your screen, please?
Oh, sorry. Let's start that again, shall we?
Yes.
Is it sharing now?
Sharing. You can go to
Perfect. Thank you. You would think I would never done this before. So this is the outline, not just what we do, but how we do it. And I want to start and end with a story. So we have funding right now from IDRC, which is a funding agency many of you might have heard of, the International Development Research Center, for a project called Women Rise, Building Back Better After COVID-19. And you're going to hear more about that throughout this talk. But there was a wrap-up meeting recently. Every single one of these projects had to involve a Canadian research partner. There was a wrap-up meeting in Nairobi, and I thought it made really good sense to send one of the postdocs from Kenya who was working on our project to represent our team. And he was great at sending back messages. This is what I'm learning. This is what's going on. But one of the messages I cannot get out of my head is the message that he shared when he said, many of the partners in the LMICs involved in this project, the low and middle income countries from Southeast Asia, Sub-Saharan Africa, other places, are saying their Canadian partners were not very good. And in fact, treated them so badly, they called IDRC to ask for new partners. I cannot get that out of my head because I don't think that's how we should be treating partners, and I don't think it means we're doing good science. Okay, so everything that I do is based on this set of principles. They used to be called the CCGHR principles, Canadian Coalition for Global Health Research principles, on how to do work in partnership around global health, but they apply to a whole bunch of different situations. The primary focus here is on equity. That's the platform, and the principles include authentic partnering. So if there's something in it for me, there has to be something in it for you. Inclusion, making sure everyone is included, and you'll hear about that when I talk about the research project I'm going to share with you today. Shared benefits, again, it has to be something in it for me, something in it for you. Commitment to the future. We're not just here today. We're going to continue to work in this partnership as we move on. Responsiveness to the causes of inequalities or inequities. So we're not just trying to cover things up. We want to look at for root causes and make change. And then humility, being humble about this situation. If you want to learn more about this, there's this great new book, came out about 1.5 years ago. The two authors, my former PhD student, Elijah Basung, who's now at Queen's University, and Katrina Plamondon, who was the primary architect of these principles, who's at University of British Columbia. Great chapters on illustrating the use and usefulness of these principles in doing research in partnership. And I just want to underscore the importance of equity. So this was an editorial that I wrote with a colleague of mine a couple of years ago, and it was about the fact that in early October 2021, that's when the malaria vaccine was released by the WHO. But it got no coverage whatsoever in the international media. Of course, we were dealing with COVID-19 at the time, but we know that malaria has killed many more people than COVID-19, and most of those are under age 5. But no recognition of this major breakthrough in the international media. That's an equity issue because it doesn't affect me, it affects them. It becomes an othering situation. So that's the background of the kind of researcher that I am, or at least the kind of researcher that I aspire to be. So I want to tell you a little story about the kind of research that I do. So of course, you know better than anybody about wash and security issues, right? All the people who lack basic drinking water, lack access to sanitation. And I'm one of those people who cannot talk about water without also talking about sanitation. And I always remind my students about, we have World Water Day on March 22nd, but when is World Toilet Day? November 19th. And access to water is, of course, shaped by power relations. Who has access to that resource? And so we use theories to inform our work, and the theory we use is the feminist political ecology of health. That is, who controls access to that resource? And we use feminist theories because we know that water is quintessentially a gendered issue, right? Water as a gendered resource is centered around 3 main themes. Women and girls are primarily responsible for water collection. And so water.org estimates 250 million hours every day women spend globally searching for water, 260 million hours every day searching for a place to relieve themselves. And women and girls experience disproportionate stress of wash insecurity. They are responsible, based on social cultural norms in many parts of the world, for providing this resource for the household, and yet they have very little power in this relationship. And one of the issues, of course, is water-related diseases. And we know that in 1972, Bradley developed the classification of diseases with respect to water. So just a quick reminder, right? So waterborne diseases are outbreaks related to water quality. You guys know all about this. Cholera is a very unpleasant way to die. It's an example of a waterborne disease. Very unpleasant way to die. But I just want to share with you, this is one of my favorite books in the world. If you've not read this book, I strongly encourage you to do so. It's the only book that can make cholera incredibly romantic. It's about a couple who meet when they were young. They fall in love. They want to get married. And it's in the late 1800s. And dad says to the young woman, you can't marry him. He's no good. He doesn't have a future. He doesn't have money. You can't marry him. So he makes her marry somebody else. She marries this somebody else. They live together for a long life. They have kids together, and then she becomes a widow. In the meantime, the fellow that she fell in love with when she was young never married, carried a torch for her, kept his love growing for her his whole entire life. And in the end of their lives, they are both on a ship in the Panama Canal. And the ship has cholera on it. And so they fly a yellow flag, which meant this ship has cholera and you can't come into port until everyone on the ship either gets better or dies. And this is the happiest time in his life because he finally has the love of his life to himself. And if you don't think that's romantic, this is the scene from the movie, which if you look up IMDb, the movie rating site, this is rated as the most romantic scene ever in a movie. So that's how romantic cholera is. If you really want to understand about cholera and how we identified water as the culprit, this book written by an investigative journalist about the cholera outbreak in 1850 inner city London and the famous John Snow map is a really, really good read. Then we have water wash diseases when there's not enough water and we can't keep things clean. Personal hygiene is compromised. Diarrhea or infections of the skin and eyes are a problem. And this is an illness that I didn't know anything about until I started working with one of my partners on the ground in Kenya. This may be very familiar to you, but I didn't know about it. Jiggers, which is the result of a flea that burrows underneath the skin and causes disfigurement. Only in very, very rare cases does it cause mortality. But you can see that it causes substantial disfigurement and incredible pain. And my friend actually runs a charity there, and she gets donations of shoes. So the kids, even if they can't wash their feet, or if they do wash their feet, if they have access to water, they can wear shoes. Because if they don't have shoes, they can't go to school. It's a requirement by the school. Water-based diseases, of course, when a pathogen is transmitted through a host that lives in the water. Schistosomiasis is a quintessential example of this. And I learned working in different parts of the world that schistosomiasis is incredibly gender-based. So if you're a woman and you're standing in contaminated water for long periods of time, doing laundry, washing children, washing other things, schistosomiasis can impact your reproductive organs and affect babies if you're pregnant and or affect your fertility. And of course, water-related diseases, because vectors or vector-borne diseases can be carried by things like mosquitoes, right? So this involves like malaria, chikungunya. I can't get a vaccine for malaria when I travel. But I'm very fortunate. I have access to healthcare, so I can get a pill that will help prevent me from getting malaria. And the last time I was traveling internationally a few weeks ago when I went to Kenya, I was given a chikungunya vaccine, which is a brand new vaccine. So we know that the estimated burden of illness for water-related diseases is quite substantial, right? 1.6 million deaths and 105 million daily adjusted life years are attributable to inadequate wash, including only diseases which could be quantified, representing 2.8% of total deaths and almost 4% of total daily adjusted life years in 2016. That's the most recent data that we have. Almost a million deaths due to diarrhea, 60% of overall diarrhea burden, 13% of the burden from acute respiratory infections, and so on and so on. 80% of the malaria burden, 100% of the burden from soil-transmitted helminth infections and trachoma. And the reference is there, and there's a definition of daily adjusted life years if that's a concept that's new to you. So this is huge. It's a big deal. But there are some gaps here. And, as a researcher, what do? We go to the literature, we see where the issues are, but then we also see where the gaps are. So as researchers, we can start filling those gaps. These are the three gaps, in my view. This is what shapes my research program and the research program of several of my graduate students whose names you will hear throughout this talk. Gender, plumbing poverty, and those two things related, water security and gender-based violence. And I'll never forget being introduced to a scientist in the Faculty of Science at my own university a couple of years ago And she was like, oh, what department are you in? And what do you do? And I said, oh, I'm in geography and I do water security and gender-based violence. And she said, oh, so you have two separate research programs. And I said, no, I work on the relationship between water security and gender-based violence. So there was, excuse me, by the JMP, a review of measures and indicators for gender in WASH. And we see here that among these, measures of safety, whether perceived or actual, tend to focus on safety while accessing WASH facilities, locations, and largely overlook violence, highlighted in green there, related to WASH responsibilities, and norms or violence related to participation in WASH committees, meetings, and events. So no one's paying attention to violence in the context of water security or WASH security. And you'll see in a few minutes why that's important. The plumbing poverty gap is a really interesting investigation by some UK researchers in the US that looks at plumbing poverty. So it's a geographical study, involved individual household records of over 117 million households using public use microdata at the block group level. And basically what they wanted to find out was who's plumbing poor in the United States of America. And we know there's some issues going on there now, but this is a country where we wouldn't expect people would not have access to water and sanitation. And guess what they found? They found that they mapped hotspots of racial and geographic inequality in US household water insecurity. So it's small, and you can go and look at the original paper, but you can see, for example, that the percentage of Black households who were had incomplete plumbing, percentage of households that were Black was 13%, percentage of households with incomplete plumbing, 17%. So overrepresentation of Hispanic households, overrepresentation of mobile home occupants, and significant overrepresentation of renters, right? So even in the United States of America, we have tremendous plumbing poverty. So plumbing incompleteness, which is how it's described in that paper, is spatially clustered in certain regions of the country and is clearly racialized. We also have to think about Canada. 1% of the Canadian population does not have access to adequate water, sanitation, and hygiene. 1% of our population. Sounds like a small percentage, but we are now close to 45 million people. It's a large number, and we know that the vast, vast, vast majority of those people come from our Indigenous populations, particularly in the North. So they are populations already made vulnerable by structural circumstances. And then let's look at what happened in the US in March 2020 when the pandemic was declared, and every single public health organization said, you have to wash your hands, you have to wash your hands, you have to wash your hands. 90 US cities had to pass legislation to force privatized water companies to turn water back on to low-income households in low-income neighborhoods in the US, because those people who couldn't afford to pay their bill to the privatized water company, their water was cut off. But we needed them to wash their hands to stem the spread of the violence. Or sorry, stem the spread of the pandemic, of the virus. I was thinking about my next slide. Sorry about that. 90 cities, major cities, Chicago, Atlanta, and so on, in the United States. But then when we go to countries like Uganda, this is a young woman who went to get water from the well. It was dark. She was alone. She was raped. She got pregnant. She didn't want to tell her family because she was so young. And of course, she would be blamed for that event. And this is a photograph taken by a friend of mine who actually did reparatory surgery on her because she was so young and her body was not yet developed well enough to give birth to a baby. So we actually see that about 20 years after the Bradley classification of diseases, the JMP went in and modified the classifications to include injury and violence associated with water collection. So now we start to see that there's a recognition of the links between wash security and violence. And we know that the vast majority of that violence is perpetrated against women. So as good researchers, now we have a gap. Now we want to try and fill that gap. What's the first thing that we do is we need to frame this somehow. And so when visiting a school recently in Ghana, I see this painted on the side of the school, showing that it's not appropriate for a man to get a woman and make her do things she doesn't want to do against her will in a violent manner when she's trying to relieve herself. This is another example in that same school, and another example in that same school. And at that school, I stood with the headmaster who showed me this beautiful set of vented pit latrines for boys and girls at that school that had been put in by UNICEF. He also showed me over here to the right of the photograph a stand of trees where adult men would wait for little girls who were going out to the bush to relieve themselves, and they would take advantage of them. So this is not just providing a place for children to relieve themselves in privacy. This is providing safety and security for young people, particularly girls. So now we've got a gap in the literature, and we want to try and do some research about this. And we know that one of the first things we do when we want to research something is we find out, what do we already know about it, right? So we do document reviews, conceptual development, literature reviews, or scoping review. Then we did some quantitative research. Then we did some qualitative research. So the first was a document review. Sorry, the numbers are a little small here, but or the text is a little small, but one of my master's students was interested in finding out, okay, it's now part of the classification of diseases. What do the major international policy documents say about violence in the context of water security? Documents written by UN Water, for example, or WHO or UNICEF. So my student, Maurice Stigoli, did an analysis of international policy documents related to water, as well as national and regional documents in 3 countries in sub-Saharan Africa, Kenya, Uganda, and Ghana, and found absolutely nothing related to violence. WASH, women, girls, and disease, women and WASH governance, menstrual hygiene, women and girls, gender-based violence, WASH, women and girls, and so on. This is UN Water in the 2030 strategy. No mention whatsoever, and not very many mentions at all in these other national and regional documents. And if you want to see more about this, Maurice has published this paper in Global Public Health, Attention to the Needs of Women and Girls in WASH, an analysis of WASH policies. And so he also followed up interviewing key informants to ask them about their views about this. So it's a combination of that document analysis as well as in-depth interviews with key informants. So then what did we do? With, at the time, my PhD student, then my postdoc, now your new staff member, Abraham Numbogu, we did a scoping review for understanding how we could frame violence against women in the context of water security. So we did a very systematic scoping review to look at the state-of-the-art water security and gender-based violence. We identified, or he identified, initially close to 11,000 records. We ended up with 29 studies. And if you think that's quite a difference, that often happens when we do systematic reviews, but these are the ones that met all the inclusion criteria. And what did we find? We found, Abraham found that this was the best way to characterize violence, gender-based violence in the context of WASH security. So we talked about physical violence, sexual violence, psychosocial violence, and structural violence. So physical violence can be, if you ever looked at DHS data, demographic and household survey data, there's a question that says, do you think it's appropriate for a man to beat his wife if there's not enough water in the household? So that's the kind of physical violence that we're talking about. In addition, there's violence that happens at the water point where women are so stressed and so distrust about making sure they have water at home that they might perpetrate physical violence on each other, or maybe a grown woman to a child, a girl. Sexual violence includes sexual assault, rape, peeping, transactional sex. And you'll see in a few minutes that some of the data from our Women Rise study talk about transactional sex for food and water. Psychosocial violence, the shame, embarrassment, fear, and stigma, and that can be something like having people at your home, but not having a place for them to relieve themselves, or having to bathe in the river or some other public water course, which can be embarrassing to you. And then structural violence, which is political and economic marginalization in the context of wash access. So a woman, who has lots and lots of other responsibilities may not get to the water point to get water for the household. If she had access to other resources like money, she would be able to pay someone to go and do that for her. But for structural reasons, she doesn't have access to financial resources in the household and or to water committees to help make decisions. And when we look at that literature review to see what proportion of studies are reporting these types of violence, we see a third of those studies were reporting physical violence, almost a third sexual violence, almost 80% psychosocial violence, and over half reporting structural violence in the context of gender-based violence and WASH. We did actually during COVID, so it was very challenging, and we had to rely on our partners on the ground, which is why doing research in partnership is so important. We did surveys in Kenya, Ghana, and Uganda at the height of COVID to ask people, you're being told to wash your hands all the time. What do you do when there's no water? So access to water, access to sanitation, coping strategies, and also experiences of violence in that context. And we particularly focused on women and also seniors. Why did we focus on those two populations? Because the UN roadmap, so the UN roadmap for building back better after COVID-19, which was written by the UN, but the primary author was a Canadian named Steve Hoffman, who was seconded to the UN to write that, lists who are the most vulnerable people in the world. And the first group is women and the second group is seniors. So we had wealth indices, water security indices, wash security indices, empowerment and wash measures, health status, both physical and psychosocial, and experiences with violence related to wash. And when we look at those four different types of wash, it was virtually 100% of the samples were reporting some form of gender-based violence in the context of wash. We followed up in two of these countries, and we're just analyzing the data from Ghana now, getting it ready for publication. But in Kenya, we followed up with 25 oral histories. Oral histories are like in-depth interviews, but they've focus on respondents who are quite senior in age. So we talked to really old women who A, had lots of lived experience in the context of access to wash over their life course, and B, don't have anything to lose anymore. So they're very candid and very open about their experiences. Pardon me. And again, in this context, 100% of the women reporting some form of gender-based violence in the context of WASH, physical, sexual, structural, and psychosocial. So again, as a result of the UN roadmap, IDRC provided funding for women building back better after COVID-19. And so we applied for and we got funding for doing work in both Kenya and Uganda. And so what I did when this funding call first came out, and this is why it's so important to think about how we're doing what we're doing. When that funding call first came out, I had existing partners on the ground in Kenya and Uganda that I had been working with for over 20 years. And I got them on a Zoom call at the same time. And I said, look, I can apply for this funding. We could get $1 million. The focus is women building back better after COVID-19. What have the greatest impacts of COVID-19 been in your communities for women? And they both said without hesitation, teenage pregnancy. I did not expect that. I expected food security issues, water security issues, economic issues. I did not expect teenage pregnancy. Why was that an issue? Because girls were no longer in school, and school is a safe place for girls. In addition, there was tremendous urban to rural migration in these parts of the world during COVID, people losing their jobs in the cities and moving back home to the villages. Households grew in size and more people were living in the households. So what did we do? Well, we were focused on this quote from the United Nations. Across every sphere, from health to economy, security to social protection, the impacts of COVID-19 are exacerbated for women and girls simply by virtue of their sex. With the spread of the COVID-19 pandemic, even the limited gains made in the past decades are at risk of being rolled back. It's important to understand the intersectional gendered implications of the pandemic, especially in the areas of gender-based violence, economic security, girls' empowerment, and inclusive leadership. That was what we were working on. So teenage pregnancy, gender-based violence, why and what should we do about it? So where did we work? We worked in 3 communities in each of Kenya and Uganda. Oh, for some reason you just see the Kenya map. Sorry about that. We also had 3 communities in Uganda just across the border, also right on the lake. We did over 2,000 surveys, 1,000 in each community, and we did them across the life course. So we worked from age 16 to 80 plus, and we had 100 women in each of 10 age categories, so we could see impacts across the life course. We also did 70 in-depth interviews and 30 oral histories, and I am not going to tell you everything that we learned, but in a very few minutes, I'm going to focus on the major findings. Food security was exacerbated during the pandemic. We asked people, did you eat less over the past few weeks because there was not enough food or money to buy food? Over 2/3 of the sample in both countries said yes. This did not vary significantly across age groups. From our one-on-one interviews, we also learned that women coped with financial hardships and food insecurity by relying on food from their backyard gardens when they could, as well as seeking help from family and friends. So social support was really important. They also reported having knowledge of women and girls engaging in transactional sex to provide for their children and families. With respect to WASH, existing insecurities were made worse. Kenyans were more likely to report paying for water. So these are the important aspects of context. In Kenya, way more people paid for water. Uganda, water was much more easily accessible for free. Many households reported not having access to a hand washing facility, many continuing to rely on the bush for sanitation, further exacerbated by high rates of urban to rural migration, family members moving back to the villages from urban areas due to lockdowns, job loss. Higher numbers of household members meant more demand for water and more work for women and girls. Access to safe water and sanitation facilities were major challenges, with women having to walk long distances to fetch water from boreholes and springs. And this increased because of the need for hand washing, and also during the dry season, women had to go further. Some reported not having access to proper or safe sanitation facilities such as latrines, posing risks for the health and safety of women and girls. In terms of health more generally, levels of COVID-19 reported were not high. We still don't quite understand if that's a reporting issue or a testing issue, but they were very aware of COVID-19 and how to prevent it. But when asked about their overall health status, about 1/3 of Kenyan women and 2/3 of Ugandan women reported that their health was only fair or poor relative to others their own age. Those are very high rates of self-reported fair poor health. This differed significantly across the life course and between countries. And it was older women who were more likely to report their health as fair poor. And these are much, much higher. In Canada, we would see somewhere around 7 to 8% of the Canadian population would report their health as fair or poor, just as a metric to compare to. Psychosocial health was measured using what's called the GHQ 20, or the General Health Questionnaire 20. Over half the sample in both countries scored above the cut point for emotional distress. This is so much higher than anywhere else that we've seen. And it didn't differ across the life course, which is also very unusual. In the literature, we see that levels of emotional distress decrease as you get older, because you've lived a good long life is good, you've got your pension, and so on and so on. Typically, we see much lower levels in older age groups. We did not see that here. And it showed about 1/4 of the women in Kenya reported improved well-being, which we also measured post-COVID-19, but many fewer women in Uganda. Pardon me, with significant differences across age groups and between countries. No health insurance in Uganda. So it's no surprise that women are reporting fair poor health. 2/3 of women in Kenya reporting no health insurance. This is a major issue, particularly because I learned from my partners that even if you have health insurance, mental health is not covered under health insurance. From the one-on-one interviews, we learned the pandemic had a significant impact on women's physical and mental health, many reporting increased stress, anxiety, depression due to loss of income, inability to meet basic needs like food, rent, and healthcare. Access to healthcare was limited, access to food was limited. So what? Women's work, health, and well-being were tremendously impacted by COVID-19, by the virus, but primarily by the indirect impacts of what else was happening. So we felt like we need to develop evidence-informed policy. Women wanted more economic empowerment, access to education, access to jobs, access to healthcare, greater support from the government. And many participants also emphasized the importance of involving women in decision-making processes at the household and community level. From the oral histories, they want to be involved in participation and in decision-making. They want to be actively engaged in local politics and community development. There are barriers to women's leadership, low education, sociocultural norms. They want empowerment, they want education, they want skills and capital for entrepreneurship, greater male support for domestic responsibilities. Much of the same, but I just want to highlight the statement in red at the bottom. These are from the oral histories when we talked to the older women. And they told us simply surviving to old age and telling one story was seen as a triumph. So what? We've got all of these great ideas from these women when we said, so what should we do about this? What do we do with that? We're the researchers. We're going to graduate students. We're going to write peer-reviewed journal articles. How are we going to affect change? In these last 5 minutes, I'm going to tell you what we're trying to do. So once we had all these data, we went back to Uganda and we went back to Kenya and we undertook deliberative dialogues. Deliberative dialogues are essentially the same as a focus group, except you bring something for people to respond and react to. So we brought the research results back to the community members from whom we collected the data, back to the policymakers and stakeholders that are on the ground to say, well, you'll see in the next slide. This is what we did. We had 4 deliberative dialogues with the community in Kenya and Uganda, with the policymakers in Kenya and Uganda. So day 1, community deliberative dialogue. Day 2, debrief. Day 3, stakeholder deliberative dialogue. Day 4, debrief. And then we went to Kenya, did the same thing. Before the deliberative dialogue, we hand-delivered invitations and a background document, which I wrote, which was everything we learned, with trying to write it in such a way that people could read it, understand it, not too much detail, but enough detail. That was a real challenge. During the deliberative dialogue, we provided an overview of the results and then had 3 recorded roundtables. The first roundtable was, what do these results mean to you? Do they resonate with you? Does this make sense to you? The second roundtable was, what can we do with these results to change policy and practice? And the third roundtable was, where are the gaps? What should we have done? What should we have asked that you wish we had asked, but we didn't? After the deliberative dialogue, we're doing a report back to the participants. So each of those roundtables, we have copious notes on the outcomes, and we are preparing a series of policy briefs, and we've got 3 new research projects on the go. And these are just some photographs of some of the deliberative dialogues. And we were really, really fortunate in Kenya. We were on Kenyan television. This is one of our PIs, Kenneth Mugienchwe, who runs our NGO in Uganda. And I've just lost Diana. She's our partner at Kohezu in Kenya. But we've got great coverage on Kenyan television. It was really, really good. So if I can find Diana here. Yeah, you can just see the level of activity, the level of engagement of these folks was absolutely outstanding. And in fact, I said afterwards at the debrief, we did not have to provide an overview of the results. Everybody read the document before they came into the room. We had really, really good feedback. One of the women in the community group, for example, is the head of a women's group for disabled women. And she said, you didn't say much about disabled women. And I said, we did document that in our data. We didn't have that many women, so that's why you didn't see it here. But now we're preparing a targeted report for her and her group about disabled women and how their issues around WASH were affected by COVID-19 and how we could address that. So I said I was going to start with a story, which was, people saying our Canadian partners weren't very good, and that just really weighed heavily on my heart. I want to end with this story, which is, this project would not have happened had it not been for 20 years of working in partnership with these organizations, building trust, building social capital, building faith in each other. These are organizations that have other things to do. They are full-time NGOs that look after the health and social care needs of their communities, but they're also committed to research and evidence-based decision-making. And so if it hadn't been us working together for all this time, this project would not have happened. The other story I want to end with is the importance of evidence in policy and practice, because the heads of our 2 NGOs, Dr. Diana Karanja and Kenneth Mugienchwe, both have research and the importance of evidence in their policy documents for their NGOs. I told you that when I first had a conversation with them and I said, what are the major issues women are dealing with because of COVID-19? And they said teenage pregnancy and gender-based violence. And what did we find in our research? Teenage pregnancy and gender-based violence. But now we have the evidence to support that, so we can talk to the policymakers, we can talk to the local politicians and say, not only are people saying this, here's the evidence. And I'm not an advocate. I can't advocate for those organizations. It's not my talent, first of all, but it's also not my place. But I can advocate for the evidence, and I can hand that evidence over to those organizations so they can advocate in their local context to make evidence-informed decision-making, evidence-informed policy and practice change. So the last thing I'll say is I'm absolutely convinced, and this is kind of my tagline and what I'm known for now, I'm absolutely convinced that if we are going to achieve Sustainable Development Goal 3, which is health and well-being for all by 2030, we will not achieve that without also achieving Sustainable Development Goal 6, which is water and sanitation for all by 2030. And neither of those 2 things are possible until we address Sustainable Development Goal 5, which is women's empowerment. That's the end of my talk. Look forward to any questions if you have any.
Yeah, thank you, Susan. Very exciting presentation and thought-provoking. I am inviting everyone to write your question in the Q&A if you have any. Uh, yes, so we have another 15 minutes for the discussion. So anyone who is attending, please write your question in the Q&A so I can uh, read them for you, Susan. So while people are writing, so I can jump in for my thing. So Susan, thank you for this. I think we all know that evidence is a very important thing. So while you go for uh, policy discussion, so there are always look for evidence. So how we can ensure? So one is like you go on a ad hoc research that you collect some data, do some focal group discussion, and then generate some evidence on case to case basis or based on your study area. So do we also need for a kind of system or policy that should be in place where these evidences or data collection or those documentation, there is a systematic process that also we should push for. So,
I'm sorry, your voice is a little muffled
yeah,
for me
I'm saying that
here.
besides these case studies, shall we also uh, do push for the need for collecting systematic data and evidence collection so that this kind of um, data that are that happening on the ground are collected and generated on the regular data collection process in the wash and health sector.
Well, I think that they are. The JMP data tell us, who has access to water and sanitation and where and how. The unfortunate thing, and I'm sure many of your audience know about this already, is that the demographic and household survey data, which gives lots and lots of information about the living and lived experiences of many households in many parts of the world, have been stopped because of the funding cuts to USAID. And access to those data is no longer available. So I guess my push would be to bring back the DHS data, but I don't know what's going to happen in that situation.
So do you think that this inaccessibility of GHS data would be a very big impact on WASH research in future?
I think it will be a big impact on lots of different kinds of research because they measure also wealth, they measure attitudes toward violence, they measure food security, levels of economic activity, and so on. Without those data, we will have no way to assess the impacts of the policy changes that we're making. So one of the things that was unique about the IDRC funded project was that we were required to have policymakers as co-investigators. So we had a senior minister from the Ministry of Gender and Seniors from Uganda, and we had the head of public health in charge of water security from Kenya. They were both co-investigators on our project. And so I think that's a fantastic way to make sure that your research results are going to be taken seriously. Unfortunately, though, a lot of research that happens, we don't build in an evaluation component, right? Because we think that evaluation, why would we spend money on evaluation when we could spend it on programming? And yet, evaluation is absolutely key because we don't know what works and what doesn't work. And I think that's going to be the biggest challenge, is not having access to ongoing data that will allow us to assess whether or not the changes that we're putting in place have an impact. So for example, there's a lot of rhetoric in the gray literature on, oh, if only women had access to water, they would spend all of the time that they were spending collecting water on economic activities or educational activities or so on and so on. But we have no evidence to suggest that that's the case. Intuitively, it makes really good sense. But say, for example, we still had DHS data 10 years from now, if we provided access to water and sanitation for all by 2030, and then in 2040, we had DHS data to say, well, look at the impact on economic activity for women. But we won't have the data to be able to say that. So I think countries need to advocate for getting those data back.
So yeah, thank you for that. So from your research, like, do you have a specific message for the policymaker how to address, like, for example, there are different situations. We can see that one is the access to water, but then another is, say, access to water. So water quality also can be issues where, like, different kind of health impact, like, for example, area where a coastal region water is saline, so women has a different kind of issues accessing water, or different kind of health impact or health issues. So do you have any specific, like, recommendation for policymakers, like, for example, how to approach these different types of gender-based violence related to water security and water access and also water quality?
So one of the things that we're seeing, for example, in Kenya and maybe in other parts of the world, but I've only physically seen them in Kenya, is water ATMs. So almost like an automated teller machine, like you see for getting cash out of the bank. They're water ATMs, and you can buy a prepaid card for a certain amount of water. You can go and get the water anytime, 24 hours a day, 7 days a week. And that's a big issue, is being able to get water on a regular basis. And then having it in a place which is well lit, maybe has security cameras, those sorts of things, so that women feel safe when they go there. It's a very simple technology, a very easy technology. And that would really go a long way. It's, the two parts of our communities, the communities that we chose to work in are very similar to the ones that you're describing. Right on the edge of Lake Victoria. Lake Victoria is the second largest freshwater body of water in the world, second only to Lake Superior from the Great Lakes in North America. Why are we having all these water issues? We have access to water. It's not safe water. It's not clean water. And so how can we make water accessible, but how can we also make it safe? And I also just want to bring back to this conversation the importance of sanitation, right? Because I don't think we can talk about water without also talking about sanitation. And we forget to talk about that. And so we don't just want to talk about making water fetching safe for women. We want to get women involved in making the decisions around how to access water, but we also want to make sanitation safe for women as well. And we hear women saying over and over again, put us on the committees, but don't just put us on the committees, listen to us when we're on the committees. Another project that I'm involved in, which is quite fascinating, is around informal water vending. It's that last mile piece, right? So it's there may be water kiosks all over town, but the woman needs it in her household. So how does it get from the kiosk to her household? So there are small scale water vendors who operate by push carts or donkeys. And some women have gotten involved in water vending, small scale water vending. So what's fascinating to me is when we talk to those women about being involved in water vending, and we talk to men about being involved in water vending, their motivations are very, very different. The motivation of the men is to have a business and make a profit. The motivation of the women, the reason they get involved in the first place, is to solve a problem. There's a problem in the community. We don't have access to water. They come together with their sisters in the community and they say, how are we going to solve this problem? And I've seen so many women's groups come together to say, okay, over the next 3 months, we're going to save, but we're going to pool our money, save up money, pool our money. We're going to drop a well and we're going to sell that water to our community members, but we're going to sell it at much lower cost than we would pay the water company. And they do that and they make a tiny little bit of profit. And then that profit, they actually run a savings and loan. So their sisters can, their sisters in the community can actually start a little vegetable kiosk beside where they sell their water. It's an amazing, amazing experience. And I think we need to understand the motivations of women and how and why they want to solve this water problem. And we need to listen to them about how they want to do it. So that structural violence piece of not involving women in this quintessential thing that impacts so much of their life is completely wrong. And that's why I say 3 through 6, 5, 5. The first thing we need to do is empower women. They will figure out how to solve the water problem, and that will lead to health and well-being for all, because we know that women are the linchpin in communities. They're the linchpin in families in terms of the health of those communities and families. So that's the final thing that I say. I just saw the 5-minute warning and I don't
Yeah,
see
thank
any
you.
other
I don't
questions
see
there.
any other questions, but I would like to ask one more. So if you can also highlight some of the things that you mentioned at the beginning that we see from the developed countries like USA or Canada, where poverty is not the cause of this same inequality. So which means that there is a, if you can just point out why it is happening here, and also it it also highlights that importance of tackling this problem not only from the poverty and access point, it's also general perspective how society looks into gender equality and gender inequality and looks into the women issues. So if you can highlight that,
Yeah,
that'd be
it's, it's easy. It's the equity piece, right? So at the beginning, I talked about the editorial that we wrote about the development of the malaria vaccine and how it got no international press whatsoever, very, very, very little. And yes, it was fighting against COVID-19, but as an international health issue, malaria still kills way more people. And it got no press because it's an equity issue. It's not me that's affected, it's them. And in the context of Canada, it's not me that's affected, it's them. And in the context of the US, it's not me that's affected, it's them. And in 2010, July 28th, 2010, the UN said water is a human right. But nobody seems to take that seriously. Nobody seems to take it as a priority. So there are still lots of households in developed parts of the world that don't have access to water and sanitation. I have a PhD student who's just about finished his PhD, who's looking at wash access in Rio in Brazil. Brazil is a middle to high income country with 35 million people who still don't have access to safe water. Why is that? It's an equity issue. It's inequity and lack of recognition of this water as a human right. So I would say, what can the United Nations UNU-INWEH do to help everyone recognize that water truly is a human right and make that happen?
thank you, Susan, and then it was very nice talk, and thank you again. With this,
Thank
I would like
you.
to end this seminar and invite everyone to next week our seminar series. Thank you, everyone. Bye.
Thank you.